The rule of three has stood the test of time in urgent primary care over the last 10 or 15 years. The rule applies to children and adults. The urgent care clinician should consider seeking paediatric review if the child has seen any healthcare professional 3 times in the previous 72 hours, using 72 hours as a guide, not an absolute. The adults are clearly unhappy if they contact health professionals 3 times in 72 hours, and we would urge a face-to-face consultation, excluding the current COVID pandemic, where a video consultation may be more appropriate. You should shorten your triage and generally not try to finish the call with advice, because if there is an adverse outcome, the adult is going to be significantly more likely to complain. We developed the rule that adults presenting with a fever of 40 or greater should be referred to the medics for assessment and bloods, including blood culture, following the death of a 45-year-old lady. In a previous role, I was also a hospital practitioner on a stroke rehab unit, and noted that adults presenting with a temperature of 40 were most uncommon. Those with pneumonias will often have a temperature greater than 39, but rarely greater than 40. We also undertook an annual audit as part of our action plan, and I would identify 10 or so patients per year presenting to AB UHB out of hours with a population of 600,000 with a temperature of over 40. So we are not significantly impacting on secondary care with this rule. I also had a medical registrar who had 2 young adults who he recognised had decompensated shortly after presenting with tonsillitis with temperatures over 40. So again, we believe this rule minimises risk with not significant impact. Transplant patients are obviously particularly complex. Their anti-rejection medication needs to be finely controlled, and the risk of drug interactions by starting antibiotics or discontinuing any of their regular medication affecting the levels of their anti-rejection medication is significant. For this reason, the forum, out of hours forum, and the transplant teams discussed this, and it was agreed that any change to a medication of a patient on anti-rejection medication should be discussed with the medical registrar of the relevant hospital. This has the added advantage that the transplant teams will be notified of the contact by the medical registrar, and they will be able to arrange personal follow-up of the patient in hours. An analysis of complaints and claims with root cause analysis identifies that there are usually predisposing factors and precipitating factors which can be readily identified as part of the investigation and resulted in the patient or family making the complaint or claim. It can even be a poorly investigated complaint which could have been managed internally is the precipitating factor for the complainant to take the issue further. So care needs to be taken. Predisposing factors may arise at any time in the patient's history. They may be relating to difficulties of access to the out-of-hours service or the in-hours general practice. It can be past poor outcomes or experience, to name just a few. Common precipitating factors are detailed below. The precipitating factor in its own right will often lead to the patient to be dissatisfied with the consultation or the outcome, but these can usually be managed through good communication, and the complaint can be averted. If there are also predisposing factors, this makes the likelihood of the complaint or claim being formally lodged much greater. Managing the expectations through the early identification of predisposing factors or the potential for a precipitating factor to arise can be really helpful in managing the patient's expectations and significantly reducing the risk of a complaint or claim. If clinicians, particularly triage clinicians, identify predisposing factors of poor access or difficulties getting through or long waits, if these can be highlighted to the clinician seeing the patient face to face, whether that is in the out-of-hours primary care centres, a home visit, or even secondary care, again it enables that clinician to be slightly more empathetic and considerate to the patient's expectations, and hopefully reducing the risk of a precipitating factor arising, causing the complaint to be lodged. Medicine management by urgent primary care is a moderately high risk area. We don't know the patients, we may not have got a full medication drug history. Allergies can be confusing, particularly if the IHR is unavailable. The risk of drug interactions with antibiotics, warfarins and statins needs to be considered given the high prescribing rate of antibiotics during the out-of-hours period. Another example where medicine management can cause complaints is through drug misuse. So I, as a triage GP, never agree to prescribe a drug liable to misuse, e.g. Benzodiazepines, methadone, unless I am very clear that the person who might need to sign the prescription is happy to progress before the patient is seen. So for example, if I identify there's a patient on methadone the pharmacist has phoned up and said there is a problem with the prescription, and they haven't had their methadone, and they normally collect it from the patient, but he can't dispense it against the prescription on a bank holiday weekend, for example, I would normally phone or message the primary care GP in the primary care centre and I'll say that I'm satisfied that this is a genuine area where the patient is not trying to manipulate the system, and confirm they are happy to issue the repeat methadone script for 1 or 2 days as needed. Obviously the decision rests with the clinician in the primary care centre, and if they are still unhappy, I would not arrange for face-to-face appointment and just tell the patient we are unable to help them. We do this as a method of being aware that we must not set up our colleagues for a fall or a confrontational consultation, and prevention is better than cure. Many years ago, in a presentation from a defence organisation, they identified that 50% of all claims were related to 5 conditions, namely meningitis and sepsis, diabetes, particularly ketoacidosis, the appendix, torsion of the testes and slipped epiphyses. Many of these conditions will present for the first time in your teenage years. Therefore, having a conscious effort to exclude these conditions, particularly in adolescents, children, will reduce the risk of a claim by 50%, which will make us all feel more comfortable in the future. Torsion of the testes is an important time-dependent condition. Consequently, all out-of-hours triage clinicians are advised that all male patients under the age of 40 presenting with acute testicular pain, particularly non-traumatic, should be referred immediately to the surgeons. The surgical team accepting the patient varies across Wales, from urology to general surgery, but A&E attendance without a specific referral is likely to delay assessment and can result in a poor outcome. Make sure you know what the referral pathway for torsion is for your out-of-hours area.